Anterolateral approach to the hip. The anterolateral approach is the approach most commonly used for total joint replacements. It combines an excellent exposure of the acetabulum with safety during reaming of the femoral shaft. Popularized by Watson Jones D. Hirsch, Personal Communication, 1981, and modified by Charlie, Harris, Hardinge, and Mueller. 6. It exploits the intermuscular plane between the tensor fasciae lati and the gluteus medius. It also involves partial or complete detachment of some or all of the abductor mechanism so that the hip can be adducted during reaming of the femoral shaft and so that the acetabulum can be more fully exposed. Figure 8-25. The abductor mechanism can be released either by trochanteric osteotomy or by detaching part of the anterior part of the gluteus medius and the whole gluteus minimus from the trochanter. 6. The two methods seem to offer different approaches, but they are actually variations on a theme. The differences should not obscure the fundamental fact that all anterolateral approaches exploit the same intermuscular plane between the tensor fasciae lati and the gluteus medius. The uses of the anterolateral approach include the following. 1. Total hip replacement 6.7. 2. Hemiarthroplasty. 3. Open reduction and internal fixation of femoral neck fractures 22. 4. Synovial biopsy of the hip. 5. Position of the patient. Place the patient supine on the operating table, so close to the edge that the buttock of the affected side. Tilt the table away from you as the patient lies flat. Both maneuvers allow the buttock skin and fat to fall posteriorly, away from the operative plane, and lift the skin incision clear of the table, making it easier to drape the patient. You must take the table tilt into account when you insert the acetabular portion of a total joint replacement because the guides used to position the acetabular prosthesis usually take the ground as their reference plane. Drape the patient so that the limb can be moved freely during surgery. Landmarks and incision. Landmarks. The anterior superior iliac spine is subcutaneous. It is easy to palpate it. The greater trochanter is a large mass of bone that projects up and back from the junction of the shaft of the femur, and the shaft of the femur can be felt as a resistance through the massive vastus lateralis on the lateral side of the thigh. See Figure 8-49. Figure 8-25. The route of the anterolateral approach to the hip joint. Figure 8-26. Position of the patient on the operating table for the anterolateral approach to the hip. Bring the greater trochanter to the edge of the table and allow the buttocks, skin, and fat to fall posteriorly, away from the operative plane. Figure 8-27. Incision for the anterolateral approach to the hip. Vastus lateralis ridge, a rough line that marks the fusion site of the greater trochanter to the lateral surface of the shaft of the femur, is easiest to palpate from distal to proximal. It is not palpable in obese patients. Incision. Flex the leg about 30 degrees and adduct it so that it is lying across the opposite knee, both to bring the trochanter into greater relief and to move the tensor fasciae lati anteriorly. Make an 8 to 15 cm straight longitudinal incision centered on the tip of the greater trochanter. The length of the incision relates to the size and obesity of the patient as well as the surgeon's experience. The incision crosses the posterior third of the trochanter before running down the shaft of the femur. See Figure 8-27. Internervous plane. There is no true internervous plane for this approach, since the gluteus medius and the tensor fasciae lati have a common nerve supply, the superior gluteal nerve. However, the superior gluteal nerve enters the tensor fasciae lati very close to its origin at the iliac crest. Therefore, the nerve remains intact as long as the plane between the gluteus medius and the tensor fasciae lati is not developed up to the origins of both muscles from the ilium. See Figure 8-25. Incise the fat in the line of a skin incision to reach the deep fascia of the thigh. Using a sponge, gently push back subcutaneous fat off the fascia lata until you can reach the fascia at the posterior margin of the greater trochanter. Incise the fascia lata at this point, entering the bursa that underlies it. Figure 8-28. Now, divide the fascia lata in the line of its fiber superiorly, heading proximally and anteriorly in the direction of the anterior superior iliac spine. Finally, complete the fascial incision by extending the cut distally and slightly anteriorly to expose the underlying vastus lateralis muscle. Elevate this flap anteriorly by getting your assistant to retract it forward, using a tissue, holding forceps. Now, detach the few fibers of gluteus medius that arise from the deep surface of this fascial flap and locate the interval between the tensor fasciae lati, which is being lifted anteriorly by the assistant, and the gluteus medius. This is best done by blunt dissection using your fingers. A series of vessels cross the interval between the tensor fasciae lati and the gluteus medius. These act as a guide to the interval, but require ligation. Figure 8-29. Next, place a right-angled retractor deep to the gluteus medius and minimus, and retract these muscles proximally and laterally away from the superior margin of the joint capsule that covers the femoral neck. Figure 830. Figure 8-28. Incise the fascia lata posterior to the tensor fasciae lati. Retract the fascia lata and the tensor fasciae lati. Envelopes, anteriorly, revealing the gluteus medius and a series of vessels that cross the interval between the tensor fasciae lati and the gluteus medius. Figure 8-30. Retract the gluteus medius posteriorly and the tensor fasciae lati anteriorly, uncovering the fatty layer directly over the joint capsule. Fully externally rotate the hip to put the capsule on stretch. Identify the origin of the vastus lateralis at the vastus lateralis ridge. Above it is the anterior aspect of the joint capsule, at the junction of the femoral neck and shaft. Bluntly dissect up the anterior part of the joint capsule, lifting off the fat pad that covers it. The fat pad can reduce postoperative scarring and adhesions and should be preserved even though it intrudes into the operative field. Figure 8-31. The safest technique is to use a swab, deep surgical dissection. Deep surgical dissection consists in detaching part or all of the abductor mechanism and then dissecting up the femoral neck superficial to the capsule of the joint until a suitable retractor can be placed over the anterior lip of the acetabulum. Two techniques improve exposure of the acetabulum by neutralizing the abductor mechanism, allowing the femur to fall posteriorly. They also permit adduction of the leg for safe femoral reaming and accurate positioning of prosthetic stems within the femoral shaft. The technique chosen depends on the prosthesis to be used. 1. Trochanteric osteotomy. Performing a trochanteric osteotomy allows complete mobilization of the gluteus medius and minimus muscles, which in turn allows excellent exposure of the shaft of the femur during femoral reaming. Palpate the vastus lateralis ridge on the lateral border of the femur, from distal to proximal. Osteotomize the trochanter using either an oscillating saw or a jiggly saw, and reflect it upward with the attached gluteus medius and minimus muscles. The base of the osteotomy should be at the base of the vastus lateralis ridge. The upper end of the osteotomy may be either intracapsular or extracapsular. The thickness of the osteotomized portion of bone varies considerably, depending on the prosthesis you intend to use. Alternatively, detach the trochanter using two cuts at right angles to one another. This will leave the trochanter looking like the roof of a Swiss chalet. This technique maximizes the bone-to-bone contact surface area and, because of its shape, also is inherently more stable after fixation than a straight osteotomy. Deflect the osteotomized trochanter upward. To free it completely, release some soft tissues including the tendon of the piriformis muscle from its posterior aspect figs. 8 to 32 and 8 to 33. 2. Partial detachment of the abductor mechanism. Place a stay suture in the anterior portion of the gluteus medius just above its insertion into the greater trochanter. Cut the insertion of this anterior portion off the trochanter. Identify the thick white tendon of the gluteus minimus as it inserts under the anterior aspect of the trochanter and incise it. The exact amount of the gluteus medius that must be detached varies considerably from case to case. Figure 8-34. In thin, non-muscular people, you may even be able to preserve the whole of the gluteus medius attachment. Figure 8-31. Bluntly dissect the fat pad off the anterior portion of the joint capsule to expose it and the rectus femoris tendon. Figure 8-32. Osteotomize the greater trochanter. Figure 8-33. Reflect the osteotomized portion of the trochanter superiorly with the attached gluteus medius to reveal the joint capsule. Figure 8-34. The joint capsule may also be exposed by partial resection of the gluteus medius tendon from the anterior portion of the trochanter. Figure 8-35. Reflect the head of the rectus femoris from the interior portion of the joint capsule. Bluntly dissect up the anterior surface of the hip joint capsule in line with the femoral neck and head. Attach the reflected head of the rectus femoris from the joint capsule to expose the anterior rim of the acetabulum. Figure 8-35 and insert. This plane is easier to open up if the leg is partly flexed, since the rectus femoris remains relaxed. Flexing the leg also keeps the femoral nerves and vessels off the stretch and farther from the operative field. Elevate part of the psoas tendon from the capsule. Because both the rectus femoris and the psoas may insert into the capsule, the plane between muscle and capsule is often difficult to establish. Place a Holman retractor on the anterior rim of the acetabulum. Make certain that the dissection and the insertion of retractors remain beneath the rectus femoris and iliopsoas, because the neurovascular bundle lies anterior to the psoas. If you cannot develop a plane between the psoas and the capsule, incise the capsule and insert a retractor around the femoral head so that you can see the joint better. Incise the anterior capsule of the hip joint with a longitudinal incision. Develop this into a T-shaped incision by cutting the attachment of the capsule to the acetabulum as far around as you can reach. Now incise the capsule transversely at the base of the neck to convert the T-shaped incision into an H-shaped one. Figure 8-36 and insert. Dislocate the hip by externally rotating it after you have performed an adequate capsulotomy. Figure 8-37. And nerves. The femoral nerve is the most laterally placed structure in the neurovascular bundle in the femoral triangle, thus the structure closest to the operative field and most at risk. The most common problem is compression neuropraxia, caused by overexuberant medial retraction of the interior covering structures of the hip joint. Less frequently, the nerve is directly injured by retractors placed in the substance of the iliopsoas. See figs 8-47 and 8-48. Vessels. The femoral artery and vein may be damaged by incorrectly placed acetabular retractors that penetrate the iliopsoas, piercing the vessels as they lie on the surface of the muscle. You can avoid this complication by making sure that the tip of the retractor is placed firmly on bone, with no intervening tissue. The anterior retractor should be placed in the 1 o'clock position for the right hip and in the 11 o'clock position for the left hip. Finding the correct plane between the rectus femoris and the anterior part of the hip joint capsule is easier if the limb is in about 30 degrees of flexion. Alternatively, avoid placing any retractors over the acetabular lip until after a capsulotomy has been performed and the femoral head excised, when the exact position of the acetabular margin is obvious and retractors can be inserted under direct vision. Figure 8-36. Incise the anterior joint capsule to reveal the femoral head and neck and the acetabular rim. If further proximal exposure is needed, incise the fascia lata proximally toward the iliac crest and along the iliac crest anteriorly. To facilitate dislocation of the hip, incise the tight fascia lata and the fibers of the gluteus maximus. Insert. The profunda femoris artery lies on the psoas muscle, deep to the femoral artery. The artery may branch off from the femoral artery just distal to the inguinal ligament, and this anatomical variant lies very close to the anterior lip of the acetabulum. The artery may be damaged by poorly placed retractors. Be aware that damage to either of these arteries may not be obvious at the time of surgery, because any bleeding that may occur may be into the retroperitoneal space and not into the surgical wound. Fractures of the femoral shaft. Femoral shafts have been known to fracture while hips are being dislocated. For that reason, it is critical that you do an adequate capsular release before attempting dislocation. To dislocate the joint, lever the femoral head out of the acetabulum with a skid such as a Watson-Jones while your assistant gently externally rotates the limb. Your assistant has a considerable lever arm during this procedure. If rotating the leg too forcibly, a spiral fracture of the femur can result. In severe protrusion of the hip, you may have to osteotomize the rim of the acetabulum, which often has an osteophyte, to achieve dislocation. If you cannot dislocate the hip without resorting to extreme force, it is safer to perform a double osteotomy of the femoral neck, excising a 1 cm portion of it, then remove the femoral head, which is lying free, with a corkscrew. Fractures of the femoral shaft also can occur when the limb is placed in full adduction and external rotation for reaming of this femoral shaft. In order for the operator to gain a good enough view of the cut surface of the femur, the femoral shaft must be adducted. If the incision in the fascia lata has been placed too far anteriorly, then the fascia lata will resist adduction, and enthusiastic assistance may cause femoral shaft fracture. This is the reason why the fascia lata should be incised initially at the posterior border of the greater trochanter. If the fascia lata gets in your way when attempting to adduct the leg, it is safest to incise it along the lines of fibers of gluteus maximus. See figure 8-36. Figure 8-37 to expose the acetabulum, dislocate and resect the femoral head. Placing 3 or 4 Holman type retractors around the lip of the acetabulum provides excellent exposure. How to enlarge the approach. Local measures. The posterior flap of the fascia lata, created during your superficial dissection, may prevent the adduction of the leg and complete dislocation of the hip needed for femoral reaming because it impinges on the trochanter. If it does, make an incision into the posterior flap of the tensor fasciae lati, heading obliquely upward and backward in line with the fibers of the gluteus maximus, which also inserts into the iliotibial tract. See figure 8-36. This maneuver may also be necessary to achieve reduction of the prosthetic hip when the leg has been lengthened by the operative procedure. If anterior retraction of the tensor fasciae lati proves difficult, use a pair of scissors to incise the fascia on the muscle's anterior aspect close to its origin from the ilium. See figure 8-36. Alternatively, continue the fascial incision farther down the lateral aspect of the femoral shaft. These maneuvers are seldom necessary. The key to a full exposure of the acetabulum lies in correctly placing retractors. Different approaches use different retractors, but 3 or 4 Holman-type retractors placed around the lip of the acetabulum, directly on bone, give as good an exposure as any. See figure 8-37. Extensile measures. Extend the skin incision down the lateral aspect of the thigh, and incise the deep fascia in line with the skin incision. Split the vastus lateralis to gain access to the lateral aspect of the femur. In this way, you can usually extend the approach to include the entire length of the femur. Distal extension is often needed when the approach is used for open reduction and internal fixation of fractures of the femoral neck. Figure 8-38, or when an iatrogenic femoral fracture occurs during femoral reaming. The approach cannot usually be extended proximally. Figure 8-38, extend the incision down the lateral aspect of the thigh, incising the deep fascia and splitting the vastus lateralis in line with its musculature to reach the lateral aspect of the femur. Lateral approach to the hip. The direct lateral approach or transgluteal approach allows excellent exposure of the hip joint for joint replacement. 25. It avoids the need for trochanteric osteotomy. Because the bulk of the gluteus medius muscle is preserved intact, it permits early mobilization of the patient following surgery. However, the approach does not give as wide an exposure as the anterolateral approach with trochanteric osteotomy. It is, therefore, difficult to perform revision surgery using this approach. Position of the patient. Place the patient supine on the operating table with the greater trochanter at the edge of the table. This allows the buttock muscles and gluteal fat to fall posteriorly away from the operative plane. See figure 8-26. Landmarks and incision. Landmarks. Palpate the anterior femur that feels like a resistance against the examining hand. Incision. Begin the incision 5 centimeters above the tip of the greater trochanter. Make a longitudinal incision that passes over the center of the tip of the greater trochanter and extends down the line of the shaft of the femur for approximately 8 centimeters. Figure 8-39. Internervous plane. There is no true internervous plane. The fibers of the gluteus medius muscle are split in their own line distal to the point where the superior gluteal nerve supplies the muscle. The vastus lateralis muscle is also split in its own line lateral to the point where it is supplied by the femoral nerve. Superficial surgical dissection. Incise the fat and underlying deep fascia in line with the skin incision. Retract the cut edges of the fascia to pull the tensor fasciae lati anteriorly and the gluteus maximus posteriorly. Attach any fibers of the gluteus medius that attach to the deep surface of this fascia by sharp dissection. The vastus lateralis and the gluteus medius are now exposed. Figure 8-40. Figure 8-39. Make a longitudinal incision centered over the tip of the greater trochanter in the line of the femoral shaft. Deep surgical dissection. Split the fibers of the gluteus medius muscle in the direction of their fibers beginning in the middle of the trochanter. Do not go more than 3 centimeters above the upper border of the trochanter because more proximal dissection may damage branches of the superior gluteal nerve. Split the fibers of the vastus lateralis muscle overlying the lateral aspect of the base of the greater trochanter. Next, develop an anterior flap that consists of the anterior part of the gluteus medius muscle with its underlying gluteus minimus and the anterior part of the vastus lateralis muscle. Figure 8-41. You will need to detach the muscles from the greater trochanter either by sharp dissection or by lifting off a small flake of bone. Continue developing this anterior flap, following the contour of the bone onto the femoral neck, until the anterior hip joint capsule is fully exposed. You will need to detach the insertion of the gluteus minimus tendon to the anterior part of the greater trochanter. Figure 8-42. Develop the plane between the hip joint capsule and the overlying muscles, using a swab pushed into the potential space using a blunt instrument. Enter the capsule using a longitudinal T-shaped incision. Figure 8-43. Osteotomize the femoral neck. Figure 8-44. Extract the femoral head using a corkscrew. Complete the exposure of the acetabulum by inserting appropriate retractors around the acetabulum. Figure 8-45. Nerves. The superior gluteal nerve runs between the gluteus medius and minimus muscles approximately 3 to 5 centimeters above the upper border of the greater trochanter. More proximal dissection may cut this nerve or may produce a traction injury. For this reason, insert a stay suture at the apex of the gluteus medius split. This will ensure that the split does not inadvertently extend itself during the operation. See figure 8-42. The femoral nerve, the most lateral structure in the anterior neurovascular bundle of the thigh, is vulnerable to inappropriately placed retractors. Anterior retractors should be placed strictly on the bone of the anterior aspect of the acetabulum and should not infringe on the substance of the psoas muscle. Figure 8-40. Divide the deep fascia in the line of the skin incision, retracting the facial edges to pull the tensor fasciae lati anteriorly. Figure 8-41. Split the fibers of gluteus medius above the tip of the greater trochanter and extend this incision distally on the lateral aspect of the trochanter until 2 centimeters of the vastus lateralis is also split. Figure 8-42. Develop this anterior flap and divide the tendon of the gluteus minimus muscle to reveal the anterior aspect of the hip joint capsule. Figure 8-43. Enter the capsule using a longitudinal T-shaped incision. Figure 8-44. Osteotomize the femoral neck using an oscillating saw vessels. The femoral artery and vein are also vulnerable to inappropriately placed anterior retractors. The transverse branch of the lateral circumflex artery of the thigh is cut as the vastus lateralis is mobilized. It must be cauterized during the approach. How to enlarge the approach? Extensile measures. The approach can easily be extended distally. To expose the shaft of the femur, split the vastus lateralis muscle in the direction of its fibers. See lateral approach in Chapter 9. The incision cannot be extended proximally. Figure 8-45. Extract the femoral head. Insert appropriate retractors to reveal the acetabulum. Apply surgical anatomy of the anterior, lateral, and anterolateral approaches to the hip. Overview. The fascia lata covers all the thigh and hamstring muscles around the hip joint. In hip surgery, its importance lies in its relationship to 3 muscles: the sartorius, the tensor fasciae lati, and the gluteus maximus. The fascia lata covers the sartorius. It also splits into a deep and superficial layer to enclose the tensor fasciae latae and gluteus maximus, figure 8-46. If the iliac crest is viewed from the lateral side, the outer layer of the covering seems to consist of the fascia lata of the thigh and the muscles that it encloses. The sartorius lies farther anteriorly. The gluteus medius, which arises from the outer wing of the ilium, is covered by the fascia lata, not enclosed by figure 8-47. The key to the anterolateral approach to the hip lies in the relationship between the tensor fasciae latae and the gluteus medius. The tensor fasciae latae, a superficial structure, arises from the anterior portion of the outer lip of the iliac crest. The gluteus medius arises from the outer wall of the ilium, between the anterior and posterior gluteal lines. The origins of the two muscles are, therefore, almost continuous, but the tensor fasciae latae is slightly more superficial, lateral, and anterior than the gluteus medius, figure 8-48. The tensor fasciae latae inserts into the iliotibial tract, the thickening of the deep fascia of the thigh, while the gluteus medius inserts into the anterior and lateral part of the greater trochanter. Thus, as the muscles run from origins to insertions, the tensor fasciae latae rises to an even more superficial position in relation to the gluteus medius, see figs 8-47 and 848. To exploit the intermuscular plane between the gluteus medius and the tensor fasciae latae, incise the fascia lata posterior to the posterior margin of the tensor fasciae latae and retract the cut fascial edge anteriorly. Because the fascia lata actually encloses the tensor fasciae latae, the muscle is retracted with the fascia, see figure 8-47. Figure 8-46, superficial musculature of the lateral aspect of the hip. All anterolateral approaches use this one intermuscular plane to reach the femoral neck. Then they follow the joint capsule medially to expose the anterior rim of the acetabulum. The techniques used in this approach differ mainly in how they detach the abductor mechanism to allow adduction of the femur for femoral reaming and retraction of the femoral neck posteriorly for adequate exposure of the acetabulum. The anterior approach is more straightforward. Two distinct muscle layers must be incised. The outer layer consists of the tensor fasciae latae superior gluteal nerve and the sartorius femoral nerve, see figure 8-14. The interval between them forms a true internervous plane. Two structures, the lateral femoral cutaneous nerve and the ascending branch of the lateral femoral circumflex artery, lie between them. They must be identified and avoided during the dissection, see figs 8-14 and 8-15. The deep layer of muscle consists of the rectus femoris femoral nerve and the gluteus medius superior gluteal nerve. The interval between them is also an internervous plane. Exploiting it is difficult, mainly because the short head of the rectus femoris originates partly from the anterior capsule of the hip joint, where the iliopsoas partly inserts, see figs 8-15 and 8-16. The lateral approach splits vastus lateralis and gluteus medius to provide direct access to the hip joint capsule. The approach is limited superiorly by the superior gluteal nerve, which traverses the substance of gluteus medius. Landmarks and incision. Landmarks. The anterior superior iliac spine is the site of attachment of two important structures. The sartorius takes its origin from it, and the inguinal ligament uses it as a lateral attachment. The anterior superior iliac spine is rarely used as a bone graft because the lateral cutaneous nerve of the thigh lies so close to it. The anterior third of the iliac crest serves as the origin for the following three muscles. 1. The external oblique forms the outer layer of the muscles of the anterior abdominal wall. It inserts into the outer strip of the anterior half of the iliac crest. 2. The internal oblique forms the middle layer of the muscles of the anterior abdominal wall. It originates from the center strip of the anterior half of the iliac crest. 3. The tensor fasciae latae arises from the outer lip of the anterior half of the iliac crest. Figure 8-47, resecting the sartorius, tensor fasciae latae, and fascia lata and reflecting the anterior portion of the gluteus maximus posteriorly reveal the gluteus medius and more anterior structures of the hip region. The fascia lata splits to envelop the tensor fasciae latae, but it only covers the gluteus medius muscle. Gluteus medius, origin, outer aspect of ilium between anterior and posterior gluteal lines and its overlying fascia. Insertion, lateral surface of greater trochanter, action, abductor and medial rotator of hip, nerve supply, superior gluteal nerve. The insertion of the external oblique and origin of internal oblique are not detached during the anterior approach, the tensor fasciae latae. The greater trochanter is the traction apophysis of the proximal femur and the site of the insertion of the gluteus medius and minimus muscles. The vastus lateralis ridge results partly from the pull of the aponeurosis of the vastus lateralis during growth and partly from the fusion of the trochanter apophysis of the shaft of the femur, figs 8-49 and 8-50. See figure 8-47, incisions. The anterior, lateral, and anterolateral incisions largely ignore the lines of cleavage in the skin, but the scars are seldom broad and are nearly always hidden by clothing. Superficial surgical dissection and its dangers. The anterior and anterolateral approaches use planes that involve the tensor fasciae latae. The anterior approach passes in front of it. The anterolateral approach passes behind it, figure 8-51. The lateral approach splits gluteus medius and vastus lateralis. Interior approach. The tensor fasciae latae and the sartorius run side by side from an almost continuous line of origin along the anterior end of the iliac crest. The two muscles diverge a short distance below the anterior superior iliac spine so that the rectus femoris can emerge from between them, see figure 8-14. Figure 8-48, the gluteus medius, gluteus minimus, and rectus femoris have been resected to reveal the muscular layers down to the hip joint capsule. Resection of the joint capsule exposes the acetabulum and the femoral head and neck. Figure 8-49, osteology of anterolateral aspect of the hip and pelvis. Figure 8-50, osteology of the lateral aspect of the hip and pelvis. The tensor fasciae latae itself is triangular. In cross-section, it is unusually slim at its origin and thick just before it inserts into the iliotibial tract. Its action is difficult to interpret because another large muscle, the gluteus maximus, also inserts into the iliotibial tract. In cases of poliomyelitis, dividing the iliotibial tract relieves flexion and abduction contractures of the hip joint. Evidence suggests that the tensor fasciae latae may be important in standing in a one-legged stance, waiting in a bus line, for instance, where the muscle may maintain the stability of the extended knee and hip. 8. The tensor fasciae latae may also have the primary function of balancing the weight of the body and the non-weight-bearing leg during walking. 26. The muscle fibers of the tensor fasciae latae are considerably finer than those of the gluteus medius, but the difference in the quality of fibers rarely makes it easier to identify the plane between the two muscles. The sartorius is the longest muscle in the body, crossing both the hip and the knee. The individual fibers within the muscle are also the longest in the body. They leave the sartorius weak but capable of extraordinary contraction. Two structures cross the plane between the tensor fasciae latae and the sartorius. Both complicate the superficial surgical dissection of the anterior approach. 1. The ascending branch of the lateral femoral circumflex artery is a comparatively large artery that often requires ligation. It is one of a series of vessels that run circumferentially around the thigh C anterior approach to the hip above. This is one of the rare instances in which a vessel crosses an internervous plane. See figs 8 to 15 and 8 to 16. 2. The lateral femoral cutaneous nerve of the thigh rises from the lumbar plexus or, occasionally, from the femoral nerve itself. From there, it descends through the pelvis on the surface of the iliacus muscle. It enters the thigh under the inguinal ligament anywhere between the anterior superior iliac spine and the midinguinal point. The nerve pierces the fascia lata just below and medial to the anterior superior iliac spine. The path it takes may vary considerably, as it can pass either around or through the sartorius muscle. See figure 8-14. It may divide into 3 or more branches just below the inguinal ligament. Compression syndromes, neuralgia paresthetica of the lateral femoral cutaneous nerve have been reported, particularly from the section that runs behind the inguinal ligament and from the point where the nerve pierces the fascia lata. These syndromes consist of painful paresthesias on the lateral side of the thigh, conditions that may be relieved by decompressing the nerve. Occasionally, decompression may have to extend into the pelvis, since the nerve may be compressed on the surface of the iliacus. Figure 8-51. The anterior and anterolateral approaches to the hip joint, showing their muscular boundaries. Anterolateral approach. One muscle, the gluteus medius, runs through both the superficial and the deep surgical dissection, mainly because its origin is relatively superficial while its insertion is deep. See figs 8-46 to 8-48. From an anterior approach, the gluteus medius appears to be one of the muscles of the inner layer over the hip joint. From an anterolateral approach, it occupies a more superficial position. There are 2 important points about the structure of this muscle, knowledge of which prevents confusion during the anterolateral approach to the hip. First, fibers of the gluteus medius commonly arise from the deep surface of the fasciae latae. This means that when you elevate the facial flap to gain access to the anterior border of gluteus medius, you often have to detach muscular fibers from the inner surface of the fascia. Although the fascia lata encloses the tensor fasciae latae muscle and covers the gluteus medius, in many cases the fascia lata actually serves as part of the origin of the gluteus medius muscle. Second, there is often a thin facial layer covering the gluteus medius muscle on its outer aspect just above the greater trochanter. In order to pick up the anterior border of the muscle for dissection, you frequently need to incise this facial layer. If you do not do this, it is difficult to pick up the anterior border of the muscle since this facial layer is continuous with the fascia covering the outer aspect of the greater trochanter. The gluteus medius is the strongest abductor of the hip. Paralysis leads to a Trendelenburg gait in which the patient cannot prevent his hip from abducting when he puts weight on the affected leg during walking. Note that bursa lies between the anterior part of the muscle and the anterior part of the greater trochanter. It may become inflamed, producing pain. One nerve, the superior gluteal nerve, crosses the intermuscular plane between the gluteus medius and the tensor fasciae latae and must be cut if the dissection extends up to the pelvis. Whether denervation of the tensor fasciae latae muscle is clinically significant is a moot point. Lateral approach. The approach splits the fibers of both gluteus medius and vastus lateralis. The anterior flap of the dissection is lifted off the underlying greater trochanter until the tendon of gluteus minimus and the anterior hip joint capsule are revealed. The exposure is made possible because it utilizes the bursa beneath gluteus medius that separates the muscle from the bone superiorly. Deep surgical dissection and its dangers. Perhaps the most difficult part of deep dissection is finding the plane between the joint capsule and the surrounding structures, because every muscle that crosses the hip joint directly sends some of its fibers to insert into the capsule. Anterior approach. The deep layer of muscles consists of the rectus femoris and the gluteus medius. The rectus femoris has 2 heads of origin, both of which must be detached. The straight head arises from the anterior inferior iliac spine. The reflected head arises from just above the acetabulum and from the joint capsule itself. The gluteus medius arises from the outer aspect of the ilium, between the anterior and posterior gluteal lines. While the intermuscular plane between the 2 muscles is easy to define and develop, the rectus is difficult to mobilize from the anterior joint capsule because part of it actually originates from the capsule itself. See figs 8-15 to 8-17. The iliopsoas muscle, which intrudes into the inferomedial portion of the operative field, must be retracted medially to expose the anterior part of the joint. The iliopsoas crosses the hip joint directly. Some of its fibers to insert into the joint capsule ilicapsularis. See figure 8-17. The iliopsoas tendon is actually the tendon for 2 muscles, the psoas major and the iliacus. The ilioptenyal bursa separates part of the tendon from the hip joint. The bursa, which may communicate with the joint itself, is usually obliterated in degenerative disease of the hip, leaving the tendon anchored to the anterior and medial portions of the joint capsule. Anterolateral approach. The femoral vessels enter the thigh beneath the inguinal ligament. They lie on the psoas major muscle, halfway between the anterior superior iliac spine and the pubic tubercle, the midinguinal point. The femoral artery is thus directly anterior to the hip joint, with the psoas muscle interposed. The femoral nerve lies lateral, and the femoral vein medial, to the artery. This arrangement can be remembered through the mnemonic VAN, vein, artery, nerve. Retractors that are placed correctly on the anterior lip of the acetabulum do not damage any of these structures, although a neuropraxia of the femoral nerve, the most lateral of the triad, may occur if retraction is prolonged and forceful. Retractors placed more anteriorly and not directly on bones are probably biting into the substance of the psoas. They can damage any of the neurovascular structures that lie in the femoral triangle. Avoiding these complications depends on keeping to the bone of the acetabular margin and staying beneath the reflected head of the rectus femoris and the iliopsoas. Lateral approach. Exposure of the anterior hip joint capsule requires division of gluteus minimus tendon. This does not appear to cause a postoperative Trendelenburg gait, however. The approach utilizes the plane between the hip joint capsule and the overlying muscles. This plane is occupied by a small amount of fatty tissue that allows the plane to be opened up by using a swab and blunt dissection. This useful plane is always present in primary surgery, but in revision surgery, it is obliterated by scar tissue. Therefore, there is inherently more risk of damaging the femoral vessels that lie anterior to the hip joint capsule in revision surgery than in primary surgery.